this next little chunk of material is really Trauma 101. So it's a neuroscience chunk of material. And I didn't used to include this in this class, but people told me over and over again that it was their favorite part was understanding the neuroscience, and that they wanted to have more background in the neuroscience in order to understand the way in which trauma promotes vulnerability to substance use disorders. And so this is our sort of like neuroscience 101, trauma and neuroscience 101. So before we dive in, what's trauma? So there are, again, stories about sort of what is trauma and what's traumatic. And if I asked you guys to tell me the dominant cultural stories about what trauma is, so many of you would just initially invoke thinking about soldiers. And we've been told such a story because of where the original diagnosis of PTSD comes from, that we sort of immediately assume that PTSD is something that happens in people that have experienced war, trauma via war. And I want to just expand on that a little bit, because again, we talked about this earlier, when we're talking about trauma here today, we're talking about multiple different things. We're talking about people that experience individual trauma, and we could be talking about sort of, I never love these terms, but I think they're pretty useful in thinking about what trauma is. People that have experienced big T trauma, which is one large traumatic event, or smaller T trauma, which is smaller traumatic events over time that are pretty consistent. We're also talking about people that have high ACEs scores, so 3 and above in terms of ACEs scores, and we'll come back to ACEs if that's not something that you feel particularly fluent in. And then we're also talking about trauma as a cultural experience. So if you're a person of color in the United States, we're talking about trauma as something that you may experience on a daily basis via racism. Or if you are a trans person, we're talking about things that you may experience on a daily basis because of transphobia. So we're talking about sort of all these different avenues today when we talk about trauma. And the one thing that I want to highlight is that trauma is not about the event. So we can't say this is a traumatic event. Well, we might say that sometimes. But in general, when we talk about trauma, we're talking about the experience of an event. So an event is only traumatic when it's experienced as traumatic. And there's a couple of core things that we know that pivot something from being an event that is not traumatic to an event that is traumatic. And a couple of those core things that sort of change the way our neurophysiology responds to it are control over the event. So if you can enact control over events, they become, by definition, less traumatic, which makes a lot of sense when we start talking about trauma-informed care, because one of the things we're always going to be doing is giving people as much control back as possible. That's because we want our care to be not traumatizing, right? The second thing that determines whether something becomes neurobiologically traumatic or not is something we call first responder response. And when I say first responder response, I'm not saying first responder and sort of reducing that to like police and fire people. I'm saying that the first person that you have some like mirror neuron connection to post the event / the first person you tell about the event. So a first responder could be a school counselor, and that's the first person that you ever told that you were being physically abused at home. That school counselor becomes the first responder. It could also be an EMT post-car accident. The way that the EMT or the school counselor interfaces with you and the trauma determines whether that event neurobiologically becomes traumatic or not, which is pretty powerful if you think about our role as people that provide services. That means that if someone tells us about a traumatic event, our response to it can alter neurobiologically how it lands in their body. That's kind of huge. It's like a heavy weight, which means we need to get really good at talking to people about traumatic events, but it's also really awesome. We have the ability to change someone's neurohormonal landscape solely by our listening skills. Whoa, that's really cool, right? So those are the two key things. So we're talking about control and then first responder response. And those are the things that shift the experience. Because again, an event is not necessarily traumatic. It's the experience of the event. So knowing that, I want you guys to sit back in your chair. And I want you to envision that there's a cop in the rearview mirror. What happens neurobiologically? Let me say this differently. What do you notice physically that changes in your body? Heart palpitations, your heart increases, heart rate increases. Yep. Breathing changes. Ooh, yes, absolutely. What else? What's that? Panic. What does panic feel like in your body? And you don't have to answer that, but I want you guys to think about that. So what's panic feel like in the body? So spend a second and just jot down a couple of things that are happening for you internally. And I want you to think for a second about how your identity or your skin tone or your gender presentation would shift this. All right, I see pens going down. You guys feel like that was enough time? I'm crunching some of these activities because we started late. But I saw a bunch of people drop their pens, so I'm going to move on. And I want to highlight here, because often I show this picture and I get a little bit of laughter. Because I think the laughter comes because so many people have the same neurobiological response to COP. Everyone gets a fear response. But often I'm speaking to mostly white rooms, and this is not necessarily a funny experience for many people. So I actually like to use this image because I think it's a really good reflection of the ways in which trauma can be so connected to who we are in the world and our identity. And then you've got this list of things, because regardless of who we are, we all have the same basic neurobiological response to a stressor or threat. So if you look at the list that you've jotted down, and then you look at the things that I've got up there, there should be considerable overlap. You should have had some heart rate increase, some breathing changes. You should have had some shakiness, some muscle tightness. Everyone kind of got some of those things? This list makes sense for you? The thing that we didn't talk about, and I didn't ask you to write down, is cognitive changes. And we'll come back to that in a second. Think about the way that your brain changed when there was a stressor or a threat. So what's actually happening here is fight or flight is being turned on because your amygdala says that something is a stressor or a threat. So the amygdala is a little part of your lower brain, I should say, and the amygdala decides whether something should be responded to as being like scary or not. The amygdala is wicked smart in this one way because it's got a little bit of intuition. So like when you meet someone and you're like, ooh, I'm not sure, I don't feel great about this, or I don't feel great about the relationship. That's usually your amygdala connecting to your stomach and doing some serotonergic stuff. So it's got some intuition, but it's also wicked dumb. It doesn't know how to differentiate true threat from non-true threat, and it just activates. And then our brain, soothes itself, but the amygdala just turns things on without really thinking about it a lot. So the classic textbook example of the amygdala and how it activates is that you're walking down the street and all of a sudden you see a snake out of the corner of your eye, and so you jump back. And then your prefrontal cortex comes online and overrides your amygdala and says, dude, it's not a snake, it's a hose, you're fine. And then you keep going. But your amygdala, in order to keep us alive, generalizes, and it overgeneralizes, and it thinks anything that's a stress or a threat, it immediately turns it on. I always think of when my kid was a toddler and was just like developing words over time. Anything with 4 legs was a dog. So we'd like be at a farm and my kid would be like, dog, and it's a cow, right? Dog, and it's a horse. The amygdala is like that. It's like threat. And then the prefrontal cortex comes online and it's like, no, that's not a dog, it's a horse, right? The amygdala really overgeneralizes, and it is the thing that decides whether something is a stressor or a threat. The amygdala sends a message down to the hypothalamus, and the hypothalamus is essentially just sort of the doorway between the brain and the body. For a long time, we've had this brain-body division, and now we know, I think, that that's really not true. And the hypothalamus is one of the primary sort of connectors between brain and body, central nervous system, and somatics. The hypothalamus sends a little message down to the pituitary, and then the pituitary gland sends a message down to the adrenal glands. And so for those of you that have some sort of fluency in the neurobiology, this is where you get the HPA axis. So the hypothalamus, pituitary, adrenal gland, that's the HPA axis that people talk about at times. And the HPA axis, oh, and I see some folks taking pictures or like just scribbling like wild. I believe you guys will get copies of this electronically. So my suggestion for you right now, pictures are awesome. I do it all the time. It's such a good way to like just capture quickly. But just try to get the concepts. If don't be worried about getting HPA axis down, just try to get the concept. And then if you are someone where you've had some fluency in this, this should help this have more context. But the HPA axis is actually not that important in what we're talking about today. Hypothalamus sends a message down. Oh, Stacy, did you want to say something? We're going to send out slides. Okay. Hypothalamus sends a message down to the pituitary and then ultimately down to the adrenal glands. The hypothalamus also sends direct messages to the fight or flight neurons, so the neurons that are adrenergic in your body. And out of the adrenal glands and those fight or flight neurons, we get catecholamines and adrenaline. And that is the cause of all the somatic experiences that you guys talked about when there was a stressor or threat. And this is pretty reductive. I'm being pretty simplistic here, but this gives you a sense of how that fight or flight system works and the story that allows you to have that experience in your body. Here's the thing though. After that initial squirt of those adrenaline and catecholamines, oh, and I should back up for a second. This is really important evolutionarily. What does this help us do evolutionarily? And just because we have such a large group, I'm not going to have people shout it out, but just try to see if you can answer it internally. This is really set up from ancestral memory to get us away from predators. This is set up to get us to fight or flight or freeze. And then nowadays, we've actually added on fawn, the idea that you will please a predator in these moments when you wouldn't otherwise do it. Is anyone else a fawner during these high stress moments? Oh my God, I will say anything in these moments to be okay and to think that I'm gonna survive, even if they do not serve me well. So fight, flight, freeze, because it's going to save us from a predator or a threat of some kind. And usually that goes away. And how many of you guys can kind of think of the somatic experience of like an adrenaline or catecholamine burst, and then a little bit of an adrenaline or catecholamine crash? Can you kind of think about how that feels? Yeah, and then you're a little bit exhausted. Yep. And then after that, we get a little bit of a squirt of a hormone called cortisol. And how many of you guys think of cortisol as being really bad? Okay, I see a couple hands, but I didn't see any like really, really excited hands. I saw a couple hands that were like this, meaning like, well, maybe. Because yes, I think that our sort of dominant narrative around cortisol, speaking of dominant narratives, is that it's really bad for you. And it's really not bad for you. But it turns out that if you're chronically stressed and you have chronically elevated levels of cortisol, it can become really bad for you. So cortisol in our body is really set up to sort of show up after adrenaline and catecholamines and manage longer term stress. So if we think about adrenaline and catecholamines as being the thing that saves us from those stressful moments, it's like a lion or a tiger is coming after us, cortisol is the thing that from an ancestral memory perspective really was there for longer periods of stress. So this would be like tribal warring, this would be droughts and famines. This is the kind of stuff that is like a seasonal, like a several month from an ancestral memory perspective, that's protecting our body in those moments and allowing us to survive when things are hard on a more daily basis. So it gets squirted out after adrenaline and catecholamines, and then it stays high when stressors don't resolve. So when every day you don't quite get enough food, you're gonna get a little bump of adrenaline and catecholamines. That's why we have the term hangry, right? People get that sort of fight experience when they don't have enough food. But then if you don't have food over a 2-week time period, that's where cortisol really comes in to allow for your survival. So cortisol does a whole bunch of stuff. One of the key things it does, get food, one of the key things that it does is it suppresses our inflammatory immune response. And this is always a little bit confusing for people because we think of inflammation as being bad, but initial inflammation is actually really good. It's what allows our body to heal from things. So if I get a little cut on my hand, I'm trying to think of, I don't know, I'm always like harming myself in bizarre ways. I'm trying to think of the last time I had a weird, I was out of the country recently and I just got like a random blister on my leg. No one could figure out what it was. Okay, so when I got this random blister on my leg, my body sent a bunch of inflammatory cytokines to that site, and they weren't bad. They're inflammatory, but they're not bad because initially inflammation is healing. So then my knee healed over the next couple of weeks because I had all this inflammatory activity there that was like white blood cells, bringing extra fluids, et cetera. And then it healed over time. And now my knee looks mostly normal again. So inflammation in the beginning is not a bad thing. But if our body is under a lot of stress, we don't necessarily want to be healing this thing on my knee or like this small hand cut. We want to preserve what our body deems as more important things. So cortisol will suppress inflammation. So the first thing you're going to see here is immune system suppression and suppression of inflammation under cortisol activity. And a lot of people know this about cortisol because we know about corticosteroids in medical practice. So does someone feel comfortable telling us what corticosteroids do within medicine? We've got some RNs in the room.
Oh, I thought it suppresses inflammation?
Oh, yes. Yeah, absolutely. Yeah, it suppresses inflammation. Yeah. So when we take corticosteroids, which is exogenous version of cortisol, it suppresses inflammation. So people would take corticosteroids for things like inflammatory asthma, inflammatory arthritis. So a lot of people know about cortisol's function in terms of inflammation suppression because we actually use it medically to suppress inflammation. But cortisol does a bunch of other stuff too. It makes us hold on to water more intensely than we usually would. And just think for a second about why that would be useful ancestrally if we were talking about periods of stress. We hold on to more water during periods of stress because for our ancestors, maybe we didn't know when the next water was going to come during tribal warring or during a drought, for example. So we're going to hold on to more water. We're also going to increase our blood sugar a little bit. which makes sense when we think about famine or warring. We just sort of increase our baseline blood sugar levels. And then right in these moments, we have a little drop of dopamine, but I'll come back to that in a second, because I mostly want to talk to you about the effects of long-term cortisol, and I want to tell you guys a little bit about sort of what happens over time with some of these key things that cortisol does. So it suppresses the immune system and it suppresses inflammation. And that's really good to keep us alive for a couple of weeks or a couple of months. But what happens if you suppress inflammation over years at a time? What do you think that would do to our immune system? Anyone have any guesses? Weakens it. So one of the things that chronic cortisol will do to our immune system is weaken it. So people are more susceptible to colds, flus, etc. And interestingly enough, one of the key things that happens is if you push down, if you sort of suppress a body system for a long enough period of time, it turns out, because of something called homeostasis, that body system will bounce back with a vengeance. So if you suppress inflammation for a really long time, what you actually get is more inflammation over time. And this is going to become one of the key things that we're going to keep coming back to. If you suppress inflammatory mechanisms in the body for years at a time, what you actually get long term is excessive inflammation and immune system dysregulation. So one of the things you see for long-term cortisol is more incidence of inflammatory illnesses. All sorts of inflammatory illnesses that have sort of root in the immune system. And there's a bunch of things that we don't even think of as being inflammatory that are actually inflammatory. So this might not be news to some of you, and to others of you, you're gonna be like, whoa, what? So did you know that we consider heart disease to be an inflammatory illness? We consider diabetes to be an inflammatory illness. We consider depression to be an inflammatory illness. And we consider schizophrenia to be an inflammatory illness. Also bipolar to a certain extent, although I think the research is not quite as complete on that one. So all kinds of illnesses are related back to dysfunction of the immune system and could be related to cortisol dysregulation. And then if we push this a little bit farther, just think for a second, and this one's a little bit tricky. I only really expect you to get this one if you're a health professional. What happens if we hold on to extra water over time? The long-term effect of holding on to a little bit of extra water becomes high blood pressure and ultimately heart disease, which is, by the way, the biggest killer in the US right now. What happens if we increase blood sugar just a little bit, but we increase blood sugar just a little bit over multiple years? What disease process does it become? That's right, diabetes. You guys all got that. And then, let's see. The other thing that happens when we've got long-term cortisol is we get a decrease in dopamine. And what is dopamine responsible for? I heard a couple people maybe say it a little bit louder. What's that? Main weave? Oh, pain relief. Dopamine, to a certain extent, is associated with pain relief, but mostly the sort of stories we have about dopamine, how many times have I said stories today? I'm gonna try to stay at less. Mostly what we think about when we think about dopamine is about pleasure and reward. And we'll come back to this pretty intensely. But what we know is that cortisol levels go up, then cortisol levels crash down, inflammation goes up, and dopamine goes down. So people have less pleasure and reward experiences in their life, as well as serotonin. And what is serotonin responsible for? Just think about it for a second. Mood, yeah. Sometimes people get serotonin and melatonin confused because they sound a lot alike. Melatonin is the sleep one. It's the one that you can buy in a bottle and it'll make you, oh, it's so lovely. It'll just like make you drift off into this really, really nice sleep. That's melatonin. Serotonin is the one that's really responsible for mood, specifically self-soothing. So serotonin is the thing where like everything is going wrong. Remember this, today was kind of like a wedding, like a rom-com wedding, and like everything that could go wrong felt like it went wrong. Serotonin was the ability, or Stacy, the organizer, and I were like, yeah, it'll probably be okay though. That's the serotonin talking, instead of like, oh my God, this is the worst thing that ever happened to us. Oh my God, life is not worth living. That's partially serotonin saying like, yeah, we got this, we're gonna be okay. Things are gonna keep going all right. So we also have a decrease, and it's an epigenetic shift. Don't worry if you don't know what that word means, just think about the concepts. It's an epigenetic shift in our serotonin receptors that means long-term cortisol actually decreases the amount of serotonin and dopamine available in our central nervous system. So less ability to self-regulate mood and less pleasure and reward activity. Okay, so let's review the stuff we just talked about. We talked about heart disease, diabetes, depression because of serotonin, although I guess I didn't make that super overt. And then we kind of talked about addiction because we talked about pleasure and reward, right? So when we think about long-term consequences of cortisol, what did we sort of just name? We kind of just named off all of the biggest killers in the US. Heart disease, diabetes, addiction, and depression. Our suicide rates are on the rise and have been for the last 30 or so years. There are places on the East Coast where morgues literally don't have enough room for bodies because of fentanyl overdose. And heart disease is the biggest killer in the US right now. So when we think about the long-term consequences of cortisol, we're really talking about the things that are really shifting our life expectancy in this country. And it's a little bit amazing that we don't talk about cortisol and its long-term effects more regularly. But I also just want to highlight when we think about this, and again, we're going back to sort of what is trauma and how do we define trauma. When we think about who is dying from those diseases more, we know that it's not equal across the board. So there's a public health concept called allostatic load, and it basically says if you experience oppression, you have disproportionate levels of cortisol, and your health outcomes are worse because of it. So if you are, for example, if you self-identify as a lesbian, you're gonna have worse health outcomes than your straight counterparts that otherwise look just like you. So again, if you experience oppression on a daily basis, your baseline cortisol levels are higher, and it influences health outcomes over time at such a huge rate that the term for it is allostatic load, and it talks about population-based health disparities. All right, so then let's get back to this idea of the story of the fight or flight response and sort of trauma 101. So there's a stressor or threat. For our purposes, we're talking about a cop in the rearview mirror. Sends a message to what? Anybody remember what? Sorry, not sends a message. What decides whether that is a stressor or a threat? The amygdala, that's right. Okay, good job. The amygdala sends a message down to the hypothalamus, which sends a message down to the pituitary gland, which sends a message to the adrenal glands, which gives us our HPA axis. Adrenal glands squirt out adrenaline catecholamines initially, and then over time, they're squirting out cortisol, which has long-term health implications if you overdo it. And this is something I want to sort of emphasize, which is cortisol is not bad for you. It's actually really good for you. It's part of survival. And you really need cortisol. You need cortisol to get out of bed in the morning. You need cortisol to have motivation and to get things going. You need cortisol to help you from getting flus and sicknesses all the time. You need cortisol. What we're talking about here is something that our bodies weren't really evolutionarily built to do, which is chronic cortisol over a long period of time. So kind of going back to this idea of like little t trauma. Although I would say even for people that don't experience what I would call trauma, in our culture, like we're a culture that's just kind of obsessed with stress, right? We love stress. We like to be busy all the time. So many of us experience the negative outcomes of high cortisol, although I would say it's disproportionate across the board. All right, so one of the things that happens with long-term cortisol and dysregulation of the immune system is that your hippocampus, which is another little part in your lower brain, actually shrinks. It gets overwhelmed. Let me back up a little bit. Your hippocampus is responsible for telling the body to chill out a little bit. When it comes to the stress or the fight or flight response, the hippocampus says, no, we're good, you can chill out. But if cortisol levels just keep going up, 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 the receptors on the hippocampus actually get overwhelmed and the hippocampus itself shrinks. So we know that kiddos, for example, that have a really high ACEs score come into adulthood with a hippocampus that is smaller than average. And people that have a diagnosis of post-traumatic stress disorder have a hippocampus that is smaller than average. So this is just one of the ways in which cortisol doesn't just change our neurohormonal landscape, but it's actually changing the way that our brain is built. So I put this in here not because it's terribly important, but I want to be really clear about sort of how profound this is, especially given its context and how minimally we talk about the long-term effects of stress. I saw a hand up in the back. Was it a question? Do you want to wait for the microphone?
Sorry, I may be nitpicking too much, but I just got confused.
Yeah.
Earlier you said that it was the prefrontal cortex that kicks in after the amygdala to say, oh, that's actually not a threat. Upon further review, you can relax. And then you also had said that the amygdala sends a message to the hypothalamus to turn on the adrenal glands. What's the hippocampus? I got lost there.
You got lost there. Okay. Yeah. So let's break it down. And it's a really good question because the hippocampus is responsible for dampening the stress response neurohormonally. It is checking the bloodstream and going, how much cortisol is there? How much cortisol is there? How much cortisol is there? And when cortisol gets up really high, the hippocampus is responsible for going, okay, like we've got enough. We don't need any more of this. And so it turns the amygdala off by saying there's enough cortisol. The prefrontal cortex turns the amygdala off by thinking. The prefrontal cortex is the part of the brain that isn't checking blood levels of any stress hormones. It's just going, no, dude, that's not a snake. It's just a hose. You're gonna be okay. So that's how those two things are different. And the hippocampus, I actually sort of now wish I hadn't put this in, but I mostly put this in because I just really want you again to see how big of a deal this is. That's my clinical vernacular for this. This is a really big deal. It changes your brain structure.
I know that the brain has plasticity. I'm just wondering, if you could exercise the hippocampus to where it grows again,
Yes.
Is that possible?
The brain has plasticity. Over time, and this is why trauma therapy is so profound, over time, you can regrow the hippocampus. Absolutely. Yeah, that's a great question.
I was going to ask a very similar question. I was just going to kind of reiterate what you said, that long-term effects of cortisol dysregulation shrinks the hippocampus. Mm-hmm. Okay, so just to say the same thing almost that he did is the hippocampus capable of regenerating itself?
Yeah, absolutely. So you can use the power of the prefrontal cortex to soothe the amygdala. You can use the power of somatic experiencing, which we'll talk about later, to soothe the amygdala. And there are various things that regrow hippocampal volume, and I can talk to you guys about that later as well. Quick preview, it's things like Prozac and lithium, which usually people don't want to hear, but it's actually pretty profound. They can regrow the hippocampus. So let's dive into this a little bit more. Hippocampal shrinkage allows for loss of inhibition in the fight, flight, or fawn system, meaning that survivors are consistently in a fight, flight, or fawn. So the hippocampus going back a little bit, it is constantly monitoring stress hormones in the blood system, and then it'll say, hey dude, chill out, to the amygdala, like we're good, we've got enough. But it shrinks over time because of cortisol. When cortisol goes up, 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 and there's no rest, there's sort of no reprieve from that, the hippocampus will shrink. And one of the things that we see in trauma survivors is chronic fight, flight, or freeze because of the hippocampal shrinkage. Because the hippocampus is partially responsible for soothing the amygdala and telling it to respond less intensely or not at all to stressors or threats. And so what do we call this sort of constant fight, flight, freeze, or fawn when we see it clinically? You guys can't scare me with silence. Usually we call it hypervigilance. Being hypervigilant, anxious, fearful, and it's a core feature of PTSD. But we see a lot of hypervigilance, which is like it's a propensity towards fight, flight, or freeze, even when there's not what we would consider to be a stressor or threat. How many of you guys see clients or people that you work with on a daily basis that see a stressor or a threat when you don't see one at all? That's funny, I was like asking rhetorically, and you guys did such an amazing job of responding to me very not rhetorically. Thank you. So that's one of the key features of PTSD, and that's sort of how we get it. The amygdala is also responsible for turning off fight, flight, freeze, or fawn, and it does that a bunch of different ways. The amygdala engages with the prefrontal cortex and tells it to activate or not. Did I read that right? Yeah, so the amygdala has sort of direct connection to the prefrontal cortex, although the amygdala is far faster than the prefrontal cortex. So think of the amygdala as like a Ferrari on the Autobahn, and I want you to think about when there's a stressor or a threat, your amygdala responds like immediately to that, before you've really had a chance to think about it. How many of you guys can recall just a stress or threat moment where you've responded to it, but you haven't actually thought about it yet? Happens all the time, right? The amygdala is directly connected to the prefrontal cortex then, and the prefrontal cortex is part of what helps the amygdala to soothe. But the prefrontal cortex, if we compare it to a Ferrari on the Autobahn, is like a bicycle on a dirt road. It's really, really slow, which is why you're walking down the street and there is what you think is a snake, and so you jump back and you've got a somatic response to it, and then the prefrontal cortex comes on much slower and says, wait a second, that's not a snake. It's just a hose, it's just a garden hose, like you're gonna be fine. The amygdala is connected to the prefrontal cortex and partially responsible for telling the prefrontal cortex whether something is truly a threat or not. So they've got a relationship, they're directly connected. The amygdala engages with all the body systems, just like we talked about, to turn on flight, fright, or freeze, so activate or calm. The amygdala also engages with sleep centers, which makes sense, right? If it's responsible for, like, are we going to activate or calm? One of the things that it is connected to and sort of partially responsible for, and this is all pretty reductive, like I'm simplifying this a lot. One of the things it's also responsible for is telling you whether you can sleep or not. How many of the clients that you work with have chronic problems with poor rest and sleeplessness, or sleeping too much? Super common. And then of course the amygdala also, in engaging with that fight, flight, or freeze, also engages with pain centers, telling us whether we should experience something as painful / a threat or not painful. So in some ways, there's this cultural narrative that pain is pain, like we've got substance P and that's what causes pain. But we actually know, and this isn't meant to say that people that are experiencing pain have psychogenic pain problems. That's not at all what I'm trying to convey. It's not like, oh, that's all just in your head. What I want to convey is that there's a huge portion of our experience of pain that's mediated by the same centers in our brain that help us respond to stressors or threats, which makes sense, right? If something's painful, our brain wants to be partially responsible for saying, is this a threat or is this not a threat to us? So when we experience pain, so much of it is interwoven with our experience of safety in the world. Does that make sense? Okay, great. That's a perfect place for a break. Before we go on a break, I want to make sure there's no lingering questions. And again, this was just sort of Trauma 101, and if you felt like that just zoomed by and you didn't get any of it, that's okay. What I would want you to get is global concepts. As long as you felt like you got a concept out of that, you're good to go, I promise.
Does the neuroplasticity piece that allows you to exercise and rebuild the hippocampus, does that also apply to the prefrontal cortex and training it to
Yeah,
be more
totally.
effective?
Yes, yeah, so the question is, although I know you have a mic, maybe I don't need to repeat it back, but just to be safe, the question is, can you exercise and engage with neuroplasticity around the prefrontal cortex as well? And yes, you absolutely can. Interestingly enough, there's not a lot that you can do directly for the prefrontal cortex, and there's some stuff you can do, but really what you do is you tampen down the amygdala and some of the other fight, flight, or freeze centers, allowing your prefrontal cortex to take up more and more space in your brain. And the big thing here, like where all the studying is, where all the academic research around this is, there's lots and lots of things, but the big thing is really meditation. Doing mindfulness and meditation about 11 minutes each day has huge implications from a neuroplasticity perspective around sort of dampening the lower brain parts of our brain that are reactive and allowing there to be more and more space for the prefrontal cortex. And we'll talk about some of that stuff more. We'll kind of loop back around to it, but that's a good question there. And then I think we should go to a break, and that means that we are going to return to our seats at 9:45. So you've got a 15-minute break, and we're going to be back here at 9:45.